Hey, everybody. Welcome to the sixth concussion consensus update and info on the SCAT 6 and the SCOAT 6. I'm Dr. Shane Bayless. I'm a concussion specialist and sports chiropractor. Our clinic is located at 308 Palladium Drive, Suite 108 in Canada, Ontario, in Ottawa, and we are ProAction Health and Performance. So today we will address what is a concussion, because that has changed in the consensus, as well as the SCAT 6 and the new SCOAT assessments that have been just implemented and released recently. So concussion defined before was a complex pathophysiological process affecting the brain and induced by biomechanical forces. That was back in 2016. Now, in the new one, they have defined it more detailed, obviously, as you can see, with a little bit more help to the practitioner of what they determine is a concussion and how it is kind of caused. So it's a traumatic brain injury in a sports-related atmosphere, because it is a sports-related concussion assessment, which was with the consensus. That is a direct blow to the head, neck, or body, resulting in impulsive force being transmitted to the brain that occurs in sports and exercise-related activities. This initiates a neurotransmitter and metabolic cascade with possible axonal injury, which is blood flow and inflammation affecting the brain. Symptoms and signs are present immediately, hours, minutes, and commonly resolve within days, which is a common concussion. There's no abnormalities on like MRIs, CT scans, X-rays, those types of things. But with different metabolic imaging like fMRI or PET scans or even tomography, those types of things, you can see some of the differences in function of the brain, where different things light up when you're thinking cognitively. Results can range in clinical symptoms and signs and may or may not involve loss of consciousness, which is something that they've kind of left in there for a while, but you don't need loss of consciousness to have a concussion. Clinical symptoms and signs cannot be explained by drug-related, alcohol-related, or medical use, or other injuries like cervical spine-related injuries, peripheral vestibular dysfunction, and other comorbidities that have similar symptoms and things like that. Now, this was done in Amsterdam this year, 2022, is when the consensus was done and when this concussion definition was created. So here's your SCAT 6, here's your athlete demographics, and then we have a concussion history where it's diagnosed concussions of the athlete has had previously, and when the most recent concussion that they've had, primary symptoms they had with that concussion, and how long was the recovery time, which we often ask our patients to begin with when they do come in with a possible concussion. Now, here's our immediate kind of flow chart talking about red flags when we need to go for an immediate medical assessment, paramedics, or going to the emergency room. So the things that they want to make sure that is ruled out is obviously positive observable signs, the Glasgow Coma Scale, neck pain, tenderness, and loss of range of motion, which can be where we're looking at spinal immobilization and cervical collars to prevent any movement of the spine that could affect the neurological system or the spinal cord. Coordination and ocular motor screen, so the eyes, and memory, and some of the questions that have to do with memory, which we use the Maddox questions. Everything's done well with those and no problems. We continue on to the full SCAT 6. So observable signs, right? We talk about lying motionless on the playing surface, falling unprotected to the surface of the playing field or arena, balance, gait difficulties, motor incoordination, ataxia, stumbling. So you've ever seen those guys that get hit in hockey and they have a hard time getting to the bench, or they can't even make it to the bench. Soccer is the same thing. Their legs become, rubbery, and they aren't standing stable, and their walk becomes, back and forth and hard to balance for themselves. You can have a vacant stare, facial injuries after head trauma, impact of seizure taking place, and high-risk mechanism injury all are referred to emergency assessment or medical assessment. The Glasgow Coma Scale, very important to have a 15 points out of this, nothing lower than 15. So we have to get perfect on all of these. So the eyes opening spontaneously when talked to, or speech or pain, verbal responses. So they're talking and they're oriented. They can talk to you pretty fluently and they know what they're talking about. So they're conscious and evaluating things well. Motor response, they can, localize where pain is. They obey commands, where's your nose, those types of things, and a lot of times you're just like, for the eye response, can you see two fingers? Those types of questions and commands. And previously we can see this picture here. This is Tua, he was the quarterback last year that got hit in the Bills game and then was hit, I think, a week later. And you can see this, the fingers that are an extension and the fingers here also an extension. That's kind of where we're looking at down here, abnormal, like withdrawal from pain or flexion or extension to pain. So these things are like, and they're stuck like this, or they may be stuck like this from a hit where the body is basically in spasm. So the red flags: neck pain and tenderness, seizure or convulsions, double vision, loss of consciousness, weakness or tingling in more than one arm or legs, because sometimes you can get a stinger in the football where it kind of just goes down one arm. You want to make sure you're finding it in both arms, as that makes it look like it's more of a spinal cord injury, and we need to be doing that. Now, vomiting, you want to see more than one vomiting. Sometimes just one vomit can be okay as a protective thing to relieve pressure from the brain. Severe and increasing headaches, so you never want to have the worst headache you've had in your life, and increasingly restlessness. So knowing that player or patient behavior, is this something that's not normal for them? Our Glasgow Coma Scale, and visible deformity of the skull. Obviously, if there's impact to the skull and there's some type of skull fracture, you want to make sure that they're getting to the hospital pretty quickly. Cervical assessment over here, we have the pain at the neck pain, any tenderness to palpation, and if there's no tenderness, is the active range of motion still full and without pain? Those are the things that we want to do a cervical collar for, make sure we don't aggravate or cause spinal cord injury to be any worse. Coordination and eye movements, so finger to nose test, right? And we're doing some ocular motor, maybe an H pattern. We're looking at the eyes going up and down, making sure the eyes are functioning well and there's no disturbances between both eyes, coordination and things like that. All right, the memory assessment. So knowing your patient is very important. Can they do this on a regular basis anyway? What venue are we at today? Which half is it? Scored last in the match? Which team did you play last week? Did your team win the last game? These questions are nothing different than the previous scats, so these are very much no change to that, but they're important to know and evaluate the patient, the player right afterwards. So off assessment. So after they're off the field, you have a little bit more of a quiet time. You should have them in a quiet room or somewhere where they can actually not be distracted by other things around. If you have time, you find out if they have previous head injuries, headache or disorder, migraines, learning disabilities, ADHD, any psychological things too, because that does prolong sometimes recovery and what you can expect from the patient when you're evaluating them. Do they have a baseline test beforehand so they can compare those? And are you suspected of a post-injury? Time elapsed since the injury, so we got to write down what the injury is, because often paramedics and doctors want to know about how long has it been since this person received a possible concussion or that trauma that happened. Right. The symptoms that we're going to be asking for right here: headache, pressure in head, neck pain, nausea, vomiting, dizziness, blurred vision, balance problems, sensitivity to light and noise, slowed down, feeling like in a fog, don't feel right, difficulty concentrating, difficulty remembering, fatigue or low energy, confusion, drowsiness, more emotional, irritability, sadness, nervousness, and trouble falling asleep. All are great questions of types of things that can affect the patient when they have a concussion. You can see here it's out of 6. Most of the time when we're asking things, it's out of 10, but for concussion wise, they do the scale out of 6 for whatever reason. Obviously 1 to 2 is mild, 3 to 4 is moderate, and 5 to 6 is severe. Oftentimes I'll even ask afterwards 0 to 10 just to get everything on the same scale and be able to compare them a little bit better. Some of these other scores like physical activity or mental activity, sometimes you can't do that if it's right after the incident, but later on you can do that. All right, so some of the orientation and cognitive, what month is it? What date is it? And I'm not really good with date anyway, so this might be something too that you want to know your patient going, would they actually know the date that day? Is it okay if they stumble with that question? Maybe, right? Day of the week, same thing. Are they really good? Are they on point every time? They're very analytical. They know all that stuff. Or are they kind of aloof, a little bit more of a space cadet, that type of thing, where they don't know those things offhand to begin with? All right, and then time within an hour. Hopefully they know the time of the game and stuff like that, and maybe they can make that assumption easily. Immediate memory. So we'll talk about immediate memory, and I'll show you the list here. So this is definitely a longer list than it used to be. So they've increased the list. It used to be 5 words. Now it is 10 words. So it makes it a little bit better to gauge what the person can do with their memory, right? So most people could get the 5 words because we're doing 3 trials with it. And by the 3rd trial, they've heard the words enough times that they can usually get that. So now we get to say, what's their mental capacity with 10 words? And we all know that our phone numbers are 7 digits long, and that's usually the capacity of someone's short-term memory is 7 digits. So this 10-word should challenge the patients to see what they are capable of. So concentration, we're doing concentration. We usually use numbers, right? Numbers are easier. Sometimes words are harder to communicate to the practitioner. These ones we usually say 493, and then you have to repeat it back to them. So it's 394. They've added an extra section, so 6 numbers rather than just stopping at 5. I've never really had many people make it past 4 to begin with, and mostly it's 3 to 4 is the general average with that. And we're only doing that 2 trials per one. So if they get 2 wrong in 1 trial, then it's over anyway, and that's their kind of their score. Here's the reverse order. I never really thought it was a difficult thing to do a reverse order of months of the year, but I've had a few players, 17, 18 years old with doing baseline testing, and they didn't know the months forwards, let alone backwards. So sometimes this is good to know your patient and knowing, can they actually do this? That's why we do the baseline testing to help us know where everybody is at skill level and cognitive level. Down here, we have coordination and balance, a modified BEST test, they call it. We do BEST test, and it's good for about 72 hours. Anything after that, you need to have a little bit more of a kind of detailed balance with usually your balance plate or a power plate or wobble boards, whatever it is that you're using to analyze that type of balance. Sometimes they even use a tandem gait walk to see where those people are at, especially after 72 hours. So we want to make sure that we're increasing that. We're doing a balance test where you're doing, as you can see here, double leg stance, tandem stance with one leg in front of the other, single leg stance. And as a soccer player, I was never really good at standing on one leg anyway when we try to do the quad stretch. So I know that I wasn't great at that. So it's good to know those baselines as well. And then they've added these options like in orange where you can actually add more to it to make it more challenging for patients that might be really good. So on the foam, you can do a double leg stance, tandem stance, and a single leg stance. And that foam takes away your ability to sense things with your feet. So you're really relying on your vision and your vestibular system, which is much more challenging than having all 3 systems put together and adding vision. Timed tandem gait. So we do this at 3 meters long. This is the same thing as before. We're walking heel to toe, 3 meters, and then you're coming back and it's all being timed. You have average trials, fastest trial, and you're going to record those data points. All right, so to increase this, we do a dual task. So we're basically getting them to do the heel to toe while they're counting backwards. And a lot of times they do it by 7s, sometimes by 3s, but here's they want to do it by 7s. We obviously test the patient first by just counting backwards. So 93, 86, 79, 72, and just get them to practice that first. And then we ask them to walk heel to toe. And then we record errors and time it takes them to finish the 3 meter walk. Now, after we have that, we have delayed recall. So that 10-word list, we ask them again to repeat as many words as they can in that 10-word list, see how well they do. A little bit more of a long-term memory challenge. And that's the end of that for the SCAT 6. Now we're going to go into the SCOAT 6, which is the first time they've had a sports concussion office assessment tool. So this is the first time, and there's a lot more detail in it, which is great because now we're getting to more details of what we've been doing in the office anyway, and they're catching up because obviously research always takes longer to be put into knowing that it's valid and reproducing the data points that we want it to. So there's your demographics again with our athletes. We have the blue, which is recommended, is needed. The green is recommended, and the orange is optional and makes more increased complexity. So current condition, obviously what happened during it. Did you walk off the field? Those types of data points. We have history of head injuries, so previous injuries. And then we have down here migraines, chronic headaches, depression, anxiety, syncope, so passing out, fainting, epilepsy, attention deficit disorder, and learning disabilities that are always good to know about that when you're talking to them about concussion and recovery periods. Medications, this is optional. What kind of medications are they taking might lead to what they might be suffering from as depression, anxiety, any other ailments they might have that they're using medications for. And family history. So family history might lend to something that we call the iceberg symptoms. So basically they're underneath the water. You're not seeing them, but they're sitting there waiting for either a traumatic injury to happen or something to affect them stress-wise that start to bring out these illnesses that might be hiding in someone's basically, in their immune system or in their nervous system that is just waiting for that opportunity to be exposed, kind of like when people get shingles, right? And times of stress or whatever, when they're exposed, shingles can come up as an illness from these stressful times. Symptoms evaluation, those are the same symptoms we talked about earlier. This is just in the SCOAT, so we're going to take those and rate them from a 0 to 6, and sometimes 0 to 10, depending on what you are comfortable as a practitioner. And then the symptoms are worse with physical activity, which you can ask them, have they been doing any physical activity? Symptoms worse with cognitive activity, reading emails, looking on the phone. What's the symptom number, the severity, those types of things. Here's our immediate test again in the SCOAT. So we're doing those testing of the words. Here's our alternative list. So you can have more lists because the lists are very repetitive. They've had the same list for a long time, but now they have 10 words in a list. So people are getting new word lists, but before it wasn't. And now we have our numbers once again. So we have our numbers here. We're going to say those backwards again and see how well we do with those. And we have our reverse months in order. Now, something new, vital signs, right? They're doing basically blood pressure and heart rate. They do it laying down for about 2 minutes. We do it 3 minutes in the clinic just to make sure that everything has settled. And then we get them to stand up. And right after 1 minute of standing, we take their blood pressure again. We do 2 sides. Most people just do 1 side, like when you do it in the doctor's office, because 2 sides usually help us out determine how you're doing autonomically. Because if it's off from 1 side to the other side, that doesn't mean it's regulating it properly, even though 1 side might be within normal ranges. We have a cervical assessment here, which is, muscle spasm, midline tenderness, paravertebral tenderness, which is the sides of the midline, just to see if there's any tenderness with the neck. And then they have flexion, extension, lateral flexion, rotation of the head, all those different motions that we want to make sure that are within normal ranges, just to make sure that there's no whiplash or injury to the cervical spine, because those can produce dizziness, nauseousness, fogginess, a lot of the symptoms from headache or from concussion anyway, that we can help out with maybe fixing the cervical spine soft tissue. We often do an upper, middle, and lower part of the cervical spine, which isn't here, but that's obviously done by practitioners' comfort for what they usually analyze and what they want to find out about the cervical spine. Neurological, so cranial nerves, taste, smell, motor. We often do it for motor. Stick out your tongue. Does it go to one side? When you say at the doctor's office, to see if the palate goes up equally on both sides. Doing with that, we look at the eye movements, pupil response with light. All those things are cranial nerves, and they're really good to analyze going, is there something else that might have been damaged during the trauma to the head? Right. Other things we have: neurological, limb tone, strength, reflexes. Often has to do with the cerebellar function. Sensation, is it equally on each side, or is it hypersensitive, hyposensitive? And cerebellar function, you can do that by alternating hands or balance with your eyes closed. Those types of things are very helpful for the cerebellar function. Each practitioner is different on how they evaluate that as well, so that's under their preference. Here's our modified best test. We talked about the 1 leg tandem stance, and then on the foam is that extra testing done as well. Time tandem gait, that 3 meters, also in the SCOAT. And then they add a little extra to the SCOAT when they say walk with your heel to toe, and then 5 steps with your eyes closed, taking away the vision system. So you're relying more on vestibular and your proprioception, which is basically how your body feels the floor and what's around you, which is going to be really good to see if there is a vestibular problem going on anyway. And then we do 1, 2 with a backwards heel to toe, just so that we can see how it goes when you're going backwards. And you do that for 5 steps as well. That can help evaluate different things in the lobes of the brain as well. We have our dual task gait. So you're doing that, and now they have different ways to make it cognitively tough, right? So it's maybe we might say visit and spell it backwards. So TISIV while you're walking. So we always attempt these cognitive tasks by practicing it first, so that they are aware of how they're going to do it, and then they have to do it while they're doing that walking backwards in this case. So it's one of those things to evaluate things, how they do cognitively and physically. Modified vestibular ocular motor, so it's called the VOMS. So this came from Pittsburgh University there with Mickey Collins, who did a lot with Sidney Crosby, but they had this thing for years now. They've been doing that, and they have the smooth pursuits, right? We're basically looking back and forth, up and down. Saccades, only side to side, looking at one target, then the other target. It's only done in the horizontal plane, not in the vertical plane. And then the VOR, so on a beep where you're looking at your target going back and forth, they call it gaze stability with the metronome at about 180. And then the VMS, which I'm looking at my thumbs, and then I'm turning my body each side and that's about 80 degrees to each side, which is done in the horizontal plane again. So they've stopped it from doing in the vertical plane. They haven't thinking that is that important, as well as they don't do near point conversion. So when they look at a target coming close, when does it become double? They also haven't used that from the VOMS. So it's a modified VOMS going forward, but it's a much better than it used to be. So we're happy that they're trying to include more details in the concussion testing. Then they have added an anxiety screen, a depression screen, and they even have the PHQ if you think that some of these questions, like little interest in pleasure in doing things, as well as feeling down and depressed and hopelessness, if you have those, then we might want to take into account a more sensitive screening and questionnaire. And the anxiety, as you can see, are you feeling nervous, anxious, or on edge, not being able to stop or control worrying too much about different things, trouble relaxing, being restless, and so on and so forth. So these are anxiety screens that they can do. And there are lots of different anxiety and depression screens. One is the HADS that they use as well. So depending on what the practitioner is comfortable with or think is recommended, we can always do further testing along those things. And if that is a problem, usually we're looking at a psychologist to help evaluate and be involved in care of the patient. All right, so we have a sleep screen now. So they're adding sleep in here, which is also awesome, right? How many hours do you get? Most of us are getting usually between 7 and 8. Obviously, more you're getting better numbers. Doesn't mean that's how much you need, but it's usually what we're looking for as a baseline. How satisfied are you with the sleep? Do you wake up refreshed or not? During the recent past, how has it been usually to take you to fall asleep each night? Sounds it's taking longer now because of the concussion and not being able to get comfortable or it just not being able to sleep. How often are you having trouble falling asleep? 3 to 4 times a week, 5 to 7, whatever it is. And then during recent past, how often have you taken medications? Melatonin, California poppy, and some over-the-counter sleep meds can also be used, trimazodone and stuff like that. So delayed word call, once again, here's our 10-word list. Do you remember them? All right, we have computerized testing. We do impact test. It's the most researched computer online test, but there are other ones that are also available that people can use. The graded aerobic exercise test. We use a graded one that goes from basically a 3-day from 65% to 70% to 75% and so on and so forth for 3 days each time. It's seeing how well they do in a graded exertion. You can do the Buffalo treadmill test as well, which is very much researched and is looked at as one of the gold standards for how people do aerobically. So management and follow-up. So here's the things, if you find any of those, exceptions with cervical spine stuff, do you want imaging? Do you have any recommendations for work, class, driving, sport, those types of things? We have our referral to an athletic therapist, physiotherapist, ophthalmologist, neurosurgeon. Obviously, the chiropractor did not make the list, which is often very common with medical doctors, but we do have specialists with chiropractors that often can be referred to as specialists like myself, and hopefully they have the good credentials as well. So it's always finding somebody that is credentialed in all our different professions. We have people that are really good at things and some people that don't really treat that type of injury. So return to learn, I'm not going to spend a lot of time return to learn, but there are obviously the new protocols they put out there as well. Activities do not result in more mild exacerbation. They talk about, only going to symptoms that go 2+ and then stop. You take a rest with that. Then you work on school activities and then you go part-time back to school and then full-time back to school. When I've worked with Dr. Goulet, it's always about getting the kids back to school really quickly, even if they're not really doing schoolwork. It's getting them back into the social aspect and them not being so worried about school and getting depressed and stuff like that by staying at home too long. Rest is usually only about 24 to 48 hours when they're recommending that as well. Okay, when we're looking at return to sport, same thing, minimum symptom problems with that. We have returned people back to sport a little bit, as in like going back to practice, even with some symptoms, because sometimes that exercise is really good to help them get past that symptom threshold and to actually give them to do exercise to create more energy and to get past some of those symptoms. So we have done that. They usually do light exercise at the beginning, and then they do more sport specific. And then we start to return them back to sport where there's no contact involved, so no chance of another head injury, and then going into a full contact practice and then return to sport. This usually takes at least a week minimum, and going forward, we're looking at doing a heart rate recording at age. So 220 is your heart rate, and then you minus your age. That usually equals out your max heart rate, and you do from a variation of that. So as you can see down here, they're doing a 55% maximum heart rate, and then to 70%. And everyone has a little bit of a different protocol. We do it with that 3 days that I talked about before. So get your practitioner to make sure that he has the proper recommendations and you know how to do it properly and safely. Right, there's your summaries of stuff of the clinical data, right? We have orientation, immediate memory, concentration, delayed recall. All those things can be written down as data points that you can record later on. And here is more of the symptoms there. So you can have different dates that you did them on and see what they're at. Dual task, fastest time, concentration, delay recall, all that stuff is there. And then, who your practitioner was, your name, your signature, and license number and all that stuff to make sure people can reach out to the person that is treating you. Summary, right? So we are better now to diagnose concussions just with more details, and people that maybe not as familiar can look at these SCAT and SCOAT and get a better understanding of how we look at concussions and testing wise. Psychological, sleep, blood pressure, exercise have all been added at a more detailed, if not new expense anyway, or not expense, but new conditions and protocols. And we have extra multitasking testing now, from walking backwards, closing the eyes, and repeating things cognitively wise to make things more challenging. So if we can screen better for acute concussions and injuries, then less people are going to have these getting persistent symptoms, because we will be able to shut them down a little bit earlier, give them the exercises that they need, not overload them, and hopefully this ongoing post-concussion syndrome or symptoms will decrease quite a bit. And we're excited about that. Now, if anybody has any more questions, please let me know. I'm Shane Bayless, Proctor Sports Injury Clinic, and we're leading the way in sports injury treatments. So give us a call, and hopefully we can help you and many others if you know of others. All right, take care, guys. Thanks again. Bye for now.